So I've got Burkitt's lymphoma. Burkitt's lymphoma is a high-grade, rare form of B-cell non-Hodgkin's lymphoma. It's more common in children and younger adults than it is in older adults. Prognosis is usually fairly well. It's more favorable if it is caught early, obviously, but usually between 60 and 80% of individuals who start the very extensive chemotherapy regimen usually can have recovery and can be in remission once treatment is finished. Usually, some of the signs and symptoms of Burkitt's lymphoma are going to be swollen nodules, lymph nodes specifically. A lot more common involvement is in the abdomen and in the jaw line. So sometimes you'll see large nodules underneath the tongue or hard masses in the abdomen. To diagnose, usually a biopsy is needed to confirm or rule out Burkitt's lymphoma, and then it's looked at under a tissue exam for further inspection. A lot of times, lab culture or lab values will also be drawn. CT, X-rays, PET scans, bone marrow biopsies, spinal taps usually will be done to see if there's any other involvement anywhere else. And then a lot of times, so a liver function and a kidney function test will be done as well to see if ALT, ASTs are elevated, or if creatinine and kidney perfusion is inadequate. Treatment usually consists of very strong, heavy doses of different types of chemotherapy. Usually, it consists of EPOC, which is rituximab, etoposide, phosphate, prednisone, vincristine sulfate, cyclophosphamide, doxorubicin. High-dose methotrexate is used at times, and various other regimens depending on if it's spread, where it's spread, and where it originates at. A lot of complications can happen, obviously, but one of the main ones, if someone doesn't go in right away, is tumor lysis syndrome. Elevated white counts, high uric acid, high phosphate, imbalanced electrolytes can all occur. This is where it becomes really crucial, and it can be lethal as well too if the patient doesn't see treatment right away. One of the big things with Burkitt's lymphoma is it is very rare, and on top of that, it happens a lot in children. Having that relationship between parent, nurse, and child is very difficult sometimes, and it's hard to manage. Parents might not understand what their kids are going through. The kids might not feel that the parents know what they're going through. So having that play into a factor as well too. Hair loss, nausea, vomiting, loss of appetite, psychosocial issues as well too are things to consider. Not being able to relate to other people, feeling secluded. Anytime you're given cancer diagnosis, these days it seems like a death sentence almost. But thankfully, with the new chemotherapy regimens that are in place, high Burkitt's lymphoma can be cured. It's very reactive and susceptible to chemotherapy treatment. Basically, I would get a patient from the ER. Complaints of nausea, vomiting, elevated temperature, usually 101 or higher. Some sign diaphoretic. Usually, if there's some lymph node involvement, there's some ascites somewhere, either in the abdomen, edema. So usually diuresis will be something they'll start in the ER. If they're suspected of tumor lysis, and it is confirmed, they'll start them on Raspuricase in the ER and then transfer them up to the floor. Majority of the time, medical background is insignificant. Sometimes you can have underlying heart failure, underlying congestive heart failure, high blood pressure, diabetes, anything like that. But for the most part, it's not insignificant to find someone that doesn't have any sort of diagnosis whatsoever on the beforehand. Things that I would look at though for a patient for my assessment portion, I want to make sure I do a good skin assessment. Low counts for platelets, thrombocytopenia can cause petechiae, extreme bruising, and internal bleeding if not treated properly. Taking a look at white counts to see if they're elevated, or if, on the other hand, if they've received treatment before, it might be low. So I want to make sure I get a good set of vitals and take a look at their white counts and their ANC as well to see if they're immunocompromised. Good lung sound auscultation, lower lobes especially. With the level of chemotherapy that we're giving, we're doing a lot of supplementary post hydration as well too, the very fast rates, usually 200, 250. So we want to make sure there's no risk for pulmonary edema as well. Making sure mobility is staying intact throughout the treatment. Patients are getting up and walking around. Pressure sores aren't prevalent. And then diet and weights are done every day as well too, just to ensure that the patient is eating properly and is not storing any extra fluid from the treatment portion. Patients that are dying from high-grade, high-risk Burkitt's lymphoma, for the most part, a lot of the prognosis is very good, but on the other hand, if there's other comorbidities, it can be difficult to treat. The cancer or the treatment is too aggressive for individuals if they get into that older age. Really having the patient the family understand that it spreads really, really fast, and it's uncomfortable. So pain management is a big one. Nausea, vomiting, lethargy, making sure the patient's comfortable, reducing temp if able, just because there's that high risk of fevers. Usually sometimes prophylactic antibiotics will be given as well too, just to ensure that nothing spreads as much. But it is fast acting. You can go from, within a 12-hour shift, it can spread very fast within that time, especially depending on what stage it's at. So informing the patient, informing the family of what's going on is the biggest portion. And if that is decided on what happens, making sure that the patient is comfortable, becomes top priority. Care plan. Treating chemotherapy or treating of the cancer will usually be done by the chemo nurse, and the provider will coordinate what regimen they want to do. But on the other hand, you're going to want to supplement their treatment with scheduled antiemetics, usually Zofran, PRN antiemetics, scheduled pain medication, PRN pain medication. Sometimes you'll get also diet or hunger stimulating medications such as Marinol or Remeron to help kind of the patient eat more and sustain themselves more from a nutrition standpoint, which will also help with the treatment side of things. Making sure the patient is getting up and walking at least 3 times a day to help circulate the blood, ensure that edema and peripheral dependent edema isn't established or isn't happening. So getting them active as much as possible. It's kind of hard sometimes with depression, sometimes with feeling of lethargy, weakness, and providing education as well throughout the shift. But the biggest part is informing patients that this may be their new normal. So that's kind of hard for patients sometimes to grasp. It's like, oh, I was feeling okay before. I was doing just fine the other day, or a few days ago, last week, I was doing okay. They're going to have a new normal, and that's going to be hard for them to push through. They might think that, if I'm not feeling good, so I'm not going to walk, or I'm not feeling hungry, so I'm not going to eat. And they have to realize that, they might not feel hungry, but they should eat 3 times a day. They might not feel like they can walk very far, but walk as far as you can and then come back and rest and then do it again later. So finding that new normal and really educating the patient on that, I think will really help a patient understand fully what's going on. You can spit all the medical jargon from the provider and all the treatment and the prognosis and all that stuff, but a full realization needs to occur, and a new baseline is set for the patient. And then once that happens, they can work off of that and hopefully become a little more prominent in their treatment plan.